Lucy, but Emma, lovely to see you with us. We have apologies from Sharon Hill, from Zoe Mayhew, from Sarah Rastrick, from Sarah Shingler, although we've got Sue Smith with us. Lovely to see you, Sue. Apologies from David Spraggart, Nicola Twigg, and Jules Walton. But Ed, lovely to see you with us as well. But we've also got a couple of welcomes. The first of all is Ashi, who's joining us as the Chief People Officer for Swift and George Eliot. So lovely to have you with us, Ashi. And we're saying goodbye, as this is the last full board meeting for a couple of colleagues. First of all, Anil, who has been a long term and under my chairmanship, a long-suffering Ned at the George Eliot. Anil has been an absolutely fantastic contributor to the success of the George Eliot. And Anil, you leave with our best wishes and heartfelt thanks for everything you've done, and we wish you well for the future. Although after the end of the last India-England cricket series, less success at the end of future test matches. And secondly, we say goodbye to Jane Ives. Jane Ives leaves us at the end of September. Jane Ives has worked with Glenn for a long while, with Glenn and I since I became chair at Swift 11 years ago, where she was originally the Chief Operating Officer, but has done an absolutely outstanding job for us at Wye Valley. Jane, you will be missed by every single person on this call. You have been an absolutely fantastic example of the values the Foundation Group stands for, and the drive and determination to do what's best for the citizens we serve and for the staff that we employ. You go with our heartfelt love, but we look forward to seeing you at the next Wye Valley board. And you're not allowed to take your foot off of the performance accelerator, but given how many points you've got on your license, I do suggest you take the foot off your car accelerator. So without further ado, any new declarations of interest? Could you please raise a digital hand for me, please? Barty?
Thank you, Russell. So it's just the minutes of the 17th of June meeting. I sent my apologies to that meeting, but there's reference in the minutes of the paper on the aseptics proposal for group, and just wanted to declare that I have been involved in my commercial capacity, consultancy capacity, in relation to development of that service model. Thank you.
Thank you, Barty. Any other declarations of interest? I just remind colleagues always to declare any interest you might have on anything, whether you regard it as relevant to the work of this board or more generally. The minutes of the meeting held on the 7th of May. Was everyone happy with the accuracy of those minutes? If not, could you raise a digital hand? Katie, thank you.
Thanks, Chair. So just one minor point that I've noted. So on page 6 of 13, where we're quoting the outturn positions, and the planned position for Wye Valley was a 3.1 million deficit, not break even. So if we could just amend that, that would be really helpful. Thank you.
Thank you, Katie, and apologies for that incorrect number. And Kim?
Sorry, that was an error. Sorry.
Okay. So any other matters or points of accuracy on the minutes? Okay, so we'll move on then to the matters arising. And bear with me, they are on page 14 of 119. And the first was the outpatients deep dive. That's been completed. Thank you very much. That goes back to last November. Sorry, we'll come back to this on November. Then we had the UEC impact on mortality and morbidity. Adam, do you just want to cover off this action point on behalf of the two of you?
Yes, so there are slightly different approaches in Herefordshire and Worcester. I'm probably not the best to comment on the Herefordshire and Worcester approach, but I know Jane is on it and will be able to give a detailed update. In Coventry and Warwickshire, we are using the integrated care record system to meet the requirements of the Respectful.
Okay, thank you, Adam. Stephen, on behalf of Hev and Worcester, is there anything you want to add, or shall I just go to Jane?
No, I'll just go to Jane. But this is one of Jane's legacies. Again, driving determination to get something through.
Jane.
This has been on my wish list for a really long time, and we are going to get our pilot up and running before I retire. I'm trying not to say the R word. It's the same. It's exactly the same approach. It'll be on the shared care record, so that everybody can see the Respect form from any part of the system. So we've got an agreement, and the agreement is going to go across Coventry and Warwickshire as well about how we do it, because there's one or two slight changes we have to make from the national guidance to make sure we get it over the line. So we're going to start that in September with a soft launch, and then it should be fully launched in November once all of the technical changes have gone through. So it's a very long wait. This is 3 years overdue from when it should have been delivered through the shared care record, but I am really pleased it's going to get there. I think it's a game changer.
Fantastic, Jane, and thank you for your hard work in that regard. And the next item was about a PIFU update, but that's coming back to us at the next 4 board meetings, so we will come back to that in due course. Any other matters arising that colleagues feel I've missed? Well, ladies and gentlemen of the public, we had our workshop this morning. We had a very important discussion on the use of AI in the foundation group, and in particular the pathfinding work that's been going on down at Wye Valley, where now over 600 of our colleagues, consultants, are using a particular piece of software to increase their productivity, reduce the admin load upon them, and improve the quality of patient care and communication and speed of communication with our stakeholders. Some absolutely fantastic work led by Jake and Adrian down at Wye Valley, but encouraged and nurtured again by Jane and the executive teams there. We also looked at the work that's going on across the foundation group. But AI is such a seismic technological change that we as a foundation group very much need to ensure we are at the forefront of seizing the appropriate and enormous opportunities that this new technology provides. It's being used elsewhere in the world to improve ED efficiency and outcomes, maternity and neonates outcomes, and the way we look after our frail elderly. So over the next 6 months, a variety of bits of work will be going on. Not least, I'll be going to visit some different countries to try and bring back to the foundation group best practice from around the world. But the work that's going on at Wye Valley, in my view, is at the forefront of the introduction of AI at the front line. So well done, that team. We then had a chat on the way we're embedding prevention into all of our activities, led by our chief strategy officers. Lots of really great work on population health management, some fantastic examples again across the foundation group. But the biggest healthcare challenge arguably we face as a country, apart from the mental health challenge for our teenagers, is that of obesity. And therefore, for members of the public who are watching the call, we have done great work in terms of smoking cessation and providing avenues to reduce alcohol consumption. We're there to help you if you want to move more and eat less, because excessive weight and obesity is the root cause of so many comorbidities that we have then as a healthcare system to look after. And it's again just worthwhile remembering that we consume 25% more calories than we did in 1960 and burn 25% less calories. But the calories we consume now are often ultra high processed foods, which are incredibly damaging to your body. So please, if you need help in terms of having a healthier lifestyle, we're there to help you. We then had an important discussion across Swift and George Eliot on our electronic patient record work, which is ongoing. This project has the potential to have an enormously positive impact for all of our staff and for our citizens in terms of the way we provide our services and we look after them. It's a process transformation work. We are worried that there is an increasing risk, though, to this project. And therefore we will be seeking all possible help from system partners who have gone through the learning on this project to help ensure that we don't replicate their mistakes, because our system partners in Coventry and Warwickshire are incredibly and disproportionately important to our own success. Glenn, do you think there's anything I've missed from that summit, or given the work that you see going on elsewhere nationally, because we haven't got a group chief executive report this month, is there anything you'd like to add?
No, I think that's a really good summary of it. I think I particularly like the AI session, and I think what's great about the project that we saw from Wye Valley is the way that we've implemented it in a small area, but it's grown because of the adoption by clinicians, because they can see the benefits, the productivity gains, the benefits for patients. So it's good to see that kind of thing happening kind of more organically because it works.
Okay, thank you very much, Glenn. Any questions to me on what we talked about this morning and what I've just said? Okay, so we'll move on then to the performance review and updates part of the board pack and the Foundation Group performance report. And Jane, as it's your last meeting with us, do you want to go first?
Russell, and I'm afraid I'm going to just start with a bit of an apology, really, on behalf of us all. This month we've tried to put in a sort of a narrative on the performance report that covers all 4 boards. I think the eagle-eyed who've read it all will see that hasn't really quite worked, hasn't really captured, I don't think, performance in the way that we want it to. So under Adam's leadership, the Group Analytics Board is going to take another look at that. So that'll be revised by the time that people see that again. But as I say, I think it's quite the standard that it was before. So to start on Wye Valley then, and I'll do my usual 3, something I'm worried about, something that's looking good, and something that we're watching carefully. So in terms of the worry, you'll be able to see on this report that our urgent and emergency care performance has really dropped in quarter 1, and we are the furthest away from our trajectory than the rest of the group. So that's something we're really worried about. So that really started middle of March and into April. So during May, and this was led by the COO, CMO and CNO, we took a lot of frontline staff out for 3 full days and really did a deep dive on what we needed to do to improve our urgent and emergency care performance. That ended up with over 20 tests of change, so all being implemented, starting the following week from when those workshops finished. And we've had a really significant improvement from that. So our performance is now 10 points higher than it was in May. We've sustained that for the last 6 weeks. We're now above our trajectory for our July performance. And so really it's now a absolutely relentless concentration on improvement of UEC, because it sort of underlies a lot of the other work that we do. So good that it's improved. Unfortunately, it has seen us go into tier 1 for our UEC performance for quarter 1, but I would absolutely expect us to come out of that after quarter 2, given the performance that we're currently seeing. The area that I'm continue to be pleased with is our cancer performance. We continue to benchmark really well against both the national standard and the national benchmarks, and so still lots of focus on that, on pathway improvement. and we're about to put in our pathway dashboard with the business intelligence system, which will be able to continue to pinpoint where are the improvements we can make on those pathways. So lots of work still going on, but our cancer performance is in the right place for where we are now. And then the third area, which we're watching carefully, well, it's more than that. It's more about explaining what's happened. It's about our mortality as expressed through the SHIMI measure. People will probably remember that 12 months ago, I was sat here with Chizo and we were crowing about how well we'd done and how far our mortality had dropped, and we were under 100 for the first time. I think we were at 98. As we sit here today, our SHIMI is 110 was the latest data, but I think it's just gone to 111. But it's a statistical issue and not a performance issue. So I thought it would be helpful just to explain that. In April of 24, Y-Valley started to record all of our SDEC performance as what's called Type 5 ED performance. And there was a national requirement for everybody to move to that reporting by July of 2024. So we moved 3 months early, and we did know we would have a bit of a hit to our mortality performance for that first 3 months. Unfortunately, most of the rest of the country then didn't do that, and actually across the group, Worcester and ourselves are recording in the new way. But George Eliot and Swift haven't moved, as they, along with most of the rest of the country. What that's meant is that nearly half of our emergency admissions are no longer being counted in the denominator for this measure. We've had a really big deep dive on this at Quality Committee, and what we've seen is our crude mortality is actually less than it was by percentage terms and in actual number of deaths. So we're really not worried about it from the point of view of we think we've got a problem, but this is going to stay as we're going to look like an outlier for at least the next 12 months. The national mandate is now, again, that from July 25, everybody should be recording their SDEC as ED type 5, but I'm not convinced that everybody has done that yet. So I just wanted to alert people to that, because from a really significant improvement, it looks like we've had a significant deterioration, but we certainly don't believe that we have.
Jane, thank you for that clarification on that point in particular. Questions and perspectives to Jane? Glenn?
I think generally the performance of Y-Valley has improved quite a lot, actually, and I'll come back later in the agenda to the national oversight framework and some of the issues around that. Really good to see that the UEC performance has picked up as well, because that was the one thing that was questionable in there. I was just going to make a general point rather than make it at each presentation from the managing directors, but having gone through the period of industrial action a week or so ago, really pleased to see the level of activity that we maintained in all 4 trusts during that period, and thanks to the operational teams for the way that they managed through that. It's sad that it's become something that we've got quite good at in terms of trying to minimise the impact for patients, but we really did see a very low drop off in activity throughout that period. So well done for everyone for making sure that patients weren't too affected by it.
No, thank you, Glenn. And I totally concur regarding Y-Valley's performance. My sense is that there is, I hope this doesn't cause any offence, my sense is a lot more grip on the financials in particular after the first quarter compared to the first quarter last year, where I know we were all very worried. So well done, Jane, Katie and colleagues, for the work you've been doing down there. We'll move on then to Catherine. Catherine, George Eliot.
Thank you, Russell. So I'm going to concentrate on the key performance indicators that are driving our NOF position, which Glenn will be talking about later. And in this month that we're reporting here, I'm afraid it's not a good news story. And why does that matter? Because this is about patients being able to access our services. And the performance in the month of June, and the cancer metrics are from May, means that patients were not being able to access our services in a timely fashion. I'm going to split them out and talk about what's happened since, because there's some improving pictures in some and some concerns in others. So I'll start where I always do, in urgent and emergency care, although they have all moved around on the board. And for other people who are looking at this, not only are we amalgamating the things at the bottom, but some of these RAG ratings are based against where you are on your plan, not against a national standard or your national ranking. So it's a bit confusing. We might want to just revisit how we're doing that. So I'm going to report against where we are nationally. In terms of urgent and emergency care, our 4-hour standard was 69.5%, which puts us in the lowest quartile 4 for that. And 10.4% of our patients waited over 12 hours in the department. That is being driven, as we've talked long before, about our bed occupancy position and flow through the organisation. In the month of July, there has been, like Jane, sustained work in terms of trying to improve that position. And in July's, just the month that's just ended, the performance on 4 hours was 76%, which would put us around the mid-table nationally in terms of 4-hour performance there. That has been driven through an improvement in non-admitted breaches, which is patients that don't need to be admitted to hospital. That improved by 10% in the month because of the work that was done by the teams in the emergency department, much like the Wye Valley story. So that's great news for both organisations. In terms of whether I am convinced about whether that can be sustained, I would draw our attention to the fact we've had 2 weeks of the first 2 weeks of the school holidays, plus a week of industrial action where the front door and wards have been staffed by predominantly senior decision makers. So that is an area which we will continue to pay significant focus to. Our challenges around bed occupancy and those patients who need to be admitted remains. As you will know, the George Eliot Board has identified a solution in terms of being able to purchase beds outside of hospital, but there remains ongoing discussions about discharge arrangements, particularly to social care from those beds, and that is slowing progress. And as you know, Russell, we're both people who like to implement the solutions where it would be the right things to do for patients. The next area is in terms of our elective performance, and we received notification this week that we have been put into Tier 1, which is the highest level of support for elective and cancer performance. In terms of our elective performance, in this month that we're reporting here, our RTT was 60.7%, and our 52 weeks as a percentage of the waiting list was 3.4%. We're now able to, and Glenn will be pleased to see that I am using this, he could report back to Jim, seeing data on a weekly basis that's being sent out from the national team. And on the week ending the 27th of July, our RTT performance had improved to 61.2%, putting us 61st out of 134 trusts. And our 52-week breaches has fallen to 2.3% of the waiting list, which puts us at 66 out of 134 trusts. And you'll see on the slide, our 52 weeks has peaked and is coming down. That was driven by ENT and gynecology capacity, and that continues to fall, and we are predicting that will continue to fall, and we're now in line with our trajectory for that. An area which has concerned me for a while and continues to concern me is our cancer performance. In this month, our cancer 62-day performance was 64.4%, which puts us 90th out of 122 trusts. And our faster diagnostic standard, which is particularly low in this month, is 66.8%, which is 108th out of 122 trusts. So an unacceptable position for our patients. The early signs in July is that is improving, and we're taking a series of actions, particularly in lower GI and gynecology, in order to drive improvement in that. So I think particularly in elective, there is evidence that the actions that we have taken to date are driving improvement. And so I hope that that is a quick in and out of tiering for the elective performance. But we will continue to have to maintain a focus on the faster diagnostic standard and maintain the improvements in the emergency department. In terms of diagnostic, performance remains amongst the best nationally, and in terms of our quality markers and workforce metrics, which are not shown on these slides, they continue to be strong. Thanks, Russell.
Thank you, Catherine. Questions and perspectives to Catherine? Catherine, I think, and this is for all the MDs, what was clear to me, having been on one of the national calls with Jim and Sarah Jane, is they are looking at performance against plan. I think the Secretary of State definitely looks at performance on national comparisons, but Jim and Sarah Jane are looking for performance against plan on the performance metrics. So if we can be conscious of the fact we might be doing well against others, but if we're well off against plan, I'm going to be involved in further national calls.
So it helps to clarify, Russell, in terms of our elective, we're now broadly on plan for all of the metrics in this month that I've just referred to. We're on plan in this month for emergency performance, but cancer performance on plan for 62 days, but off plan for 28-day faster diagnostic standard, if that helps to be clear for the board.
Thank you very much, Catherine. I think there are learnings for all of our boards, so in terms of the phasing of our plans, and this isn't a point on George Eliot, it's a general point, that I think on occasion we do shoot ourselves in the foot. And again, this is a general point, not a George Eliot point, on the phasing of our plans. So when we get into the next planning cycle, I think the phasing of our plans is going to be important. Any other questions to Catherine? Okay, so we'll move on to Worcestershire Acute and Stephen.
Thanks. Again, probably similar to others, I'll pick on the main headlines. So in terms of UEC, we have seen a slower improvement than we would want in EAS, but it is improving. The really helpful thing for us behind that, which you can't see on it, but to give some context for the board, is some of the other metrics that sit around UEC. So we're seeing a definite improvement in 12 hours within the department, but also a big significant one that's taken quite a bit of effort to move, and a lot of focus is around our occupancy, and that is starting to significantly drop through the drop, and that will lead through into the EAS improvement. We have been in tier 1 and we have been receiving support, particularly for frailty, but also with our community partners, and we're starting to see some of that work come through, particularly the clinical work that is now happening between the community hospitals and ourselves. And one that we're really, really pleased about and is starting to show some real benefit is around the stroke pathway, where our clinicians are outreaching into the community hospital, and we're starting to see some quite significant drops there in length of stay. And to support that, we've done a bit of internal movement around. So we moved trauma to a slightly bigger bed base, and we've just done that with stroke in the last 2 weeks. Again, early indications are through the divisions that's looking really positive and starting to put us in good shape, one, to improve, but also we'll touch on winter coming. In terms of cancer, there are 2 main issues for us, so skin and breast, which are really driving our performance. What's pleasing is that we've just launched a new teledermatology service, and breast have been recruiting and have got extra capacity, so we have a trajectory that by September those will start to really recover. And around elective, we've still got what we've termed, we've pinched one of our regional directors' phrases for our over 65 weeks of yesterday's work around ENT, and we've got some options around that. But we're still really, really focused on that. And again, there's some really good signs of productivity through the divisions, particularly around orthopedics. Those 3 things are the ones that really drive a lot of the other metrics that we'll probably talk around. So particularly our urgent care issues around flow really do underpin a lot of the quality metrics that we look at. And what's really helpful is, again, for the board, as that is dropping, we are start to see a correlation as well between other areas dropping, falls, and various other things that we look at. And effectively, that's what's driving our financial position as well. So as we get ourselves in the best shape possible for the last 6 months of the year, we'll keep a really close eye on that. As others have mentioned, we are tiered, just for completeness, we are tier 2. We're expected tier 2 for cancer, but we are expecting to drop a level in urgent and emergency care. So we won't be tier 1, we'll drop to tier 2. But we have been keen to keep that support around our frailty model that we've been working with them on, and it looks really positive. That's the update for us, Chair.
Thank you, Stephen. Questions and perspectives to Stephen. Glenn?
Just on that point of the tiering experience that we've had at Worcestershire Acute, I know Chris is going to meet with COO colleagues elsewhere in the group, because there's obviously an opportunity to learn from that with one or two other bits of the group going into tiering. I mean, my own experience of it is it's quite time consuming and to be avoided. But actually, when you look at the UEC performance at Worcestershire Acute, I think particularly the handover delays that we prioritised has been quite a marked improvement. And actually, when you look beneath the surface, the two sites, the Alex, generally the performance on the Alex site has been pretty good actually over the last period. So we've still got some issues at the Worcestershire Acute site to resolve, which is obviously where some of the bigger urgent care demand is.
Thank you, Glenn. And I guess a quick question for me, Stephen, and we'll move on to Adam. Stephen, in terms of the community care beds project, as I'll call it, with our colleagues in the Partnership Trust, which is absolutely key for us to ensure flow. How's that going?
So building on what Glenn was saying about the tiering was actually quite helpful in us galvanising really and moving that forward at pace. And the other bit I would give quite a bit of credit to as well is Ellen coming in as a chief exec of the Community Mental Health Trust has really put a lot of emphasis behind it. So we're starting to see that benefit come through, and Chris might touch on it. Those that know the place, we've got a pathway discharge unit that we have. I think it adds more delay, to be honest. That is one area that we are starting to see reduce its occupancy more frequently and on a regular basis. And I think that's the first indication from a numbers point of view that we've got that this work is now starting to really come through for us. I think the next step, the crucial next step, is taking the stroke model is where our clinicians can play in to accelerate that even further. So I think at the minute we're starting to see some really good signs. We've just got to keep that pace going. I think you might be on mute, Russell.
Chris, if I can ask you in the next item on the agenda to sort of pick up on the importance of that project on making sure our winter plans are robust and effective, that would be super. You're probably going to do it anyway. Thank you. So, Adam, how are you seeing things at Swift?
Thank you, Russell. Similarly, I'll focus on some of the key North measures. And if I do, first of all, the one that we're most concerned about, which is cancer performance, where we are behind plan and again will be placed in tier 2 regional scrutiny for this. I think there's 3 issues that contribute to the various aspects of cancer performance. The first we've spoken about here and in our trust board previously, which is access to oncology from our tertiary provider at UHCW, and this provides a really significant challenge with the 62-day target. Obviously, we can't get oncologists, then we can't meet that target. We have been working really closely with UHCW to manage that. Obviously, they have challenges of their own, but we have good working led by Harkamel, Bhaskar and Fiona to work with UHCW to speed up and improve some of the pathways there and make sure we've got the resource we need to address the challenge. We also are looking at mutual aid from other other partners, including Worcester, indeed, to address some of the challenges there. So thank you to partners who've been involved with that. I think a couple of the other challenges we're seeing in that pathway are the really significant referral increases we've seen in some specialties. So if we take head and neck as an example, we've gone from around about 160 referrals in June last year to I think it was 196 in the same period this year, and clearly that kind of 25% increase in referrals has an impact, and we see that most particularly in the faster diagnosis areas. But we are working with teams to make sure we've got the right capacity, and I think some of the changes we've made in relation to faster diagnostics have helped that certainly over the last year. The final challenge is one that's very specific to our dermatology service, dermatology being one of our highest referral specialties, and there have been some sickness issues there, which meant we've got less staff available than we normally would. To support that, we have put in place some insourcing in August to address the particular issues that we see there. If I move on to RTT, the good news there is we have no waits over 65 weeks. We've had a long-standing issue with orthodontics. This is a national issue related to capacity in orthodontic service and availability of consultants there. Thanks to support from partners and the region, we've been able to address all of the long waits there now, which was a significant effort. So well done to the teams for doing that. And again, across the board, we're keeping those long waits down. Having said that, we are a bit off plan for RTT this month. That predominantly relates to the challenges in dermatology, and we're confident that the insourcing we're putting in place this month will help to address that and get us back on track. So we're watching really carefully, but I think good plans there to improve. Finally, I want to mention ED performance. So a really positive story there. We have had, over the last couple of months, some of our busiest ever months for number of attendances at the front door. But despite that, we are ahead of our planned trajectory for the ED 4-hour standard. And we're also maintaining our really good performance in terms of ambulance handovers and in terms of 12-hour waits in the emergency department. And that is thanks to the work that our emergency teams have put in terms of making sure our processes are good in ED, but also making sure the wider hospital is supporting flow. So some excellent work there. And just to reassure the boards, we have seen that performance sustained and improved in July, despite again the very high referral numbers we've seen. So those are the key points, Russell.
Thank you, Adam. Any questions or perspectives to Adam? Glenn?
I'll probably just make a point on all of our trusts, actually, which I've made elsewhere, which is we're still only measuring the 4-hour standard as the UEC measure, but actually in all of the pathways, there's lots of pathways now that patients are getting really rapid urgent care, whether that's through ambulances doing treat and leave, whether that's through call before convey solutions and outreach and community services, whether that's through straight to same day emergency care. So just to reassure the public that whilst we look at the 4-hour standard, that's probably only about 60% of the urgent care now that takes place around our sites, and patients are going through much more rapid pathways elsewhere.
No, point well made, Glenn. And Stephen?
Yeah, it was just to pick up on the cancer points that I think we've all made. So David Mowbray and I had an action from one of the board workshops around getting, we're going to get the cancer leads back together for the trusts and really kind of start to map out where we see some of that improvement and kind of getting a real plan behind that. That we're going to schedule that for September, so we'll keep the board updated on that. because actually we've got quite a population number and we will be dealing with the same tertiary partners. So it's not to move activity, but it's just to work out what we're actually doing, that collectively we can get faster traction on those things.
Yeah, I think that's an incredibly important piece of work, Stephen, because, you know, as Adam's indicated, and you've all indicated, referral numbers on cancer are increasing. We know the disproportionate emotional turmoil that a potential cancer diagnosis or a cancer diagnosis puts on the individual and their families. And we know there is a shortage. So I think looking at alternatives is going to be very important for us across the foundation group to increase supply. I do worry greatly that with UHCW having been put into tier 1 for cancer performance in May of this year, and more recently into tier 1 on an exceptional basis for the elective performance, as our tertiary across Coventry and Warwickshire, and I know Worcestershire rely on them also, we really do need our tertiary to perform in those services that our citizens require. And if they're not able to perform, or not able to perform in a reasonable time frame, on behalf of our citizens, we need to find alternatives. I'd also make the point, though, that in terms of our service level agreements, not just on this type of issue, but when it comes to industrial action, we actually pay our tertiary for work which is promised and contractually agreed between us. If they don't pay, or if they don't provide the service, we shouldn't pay the SLA. So I think we need to be a bit cannier on understanding our service level agreements. And I say that to all of our finance directors and the bills that come in. The final point is that I think going forwards, managing directors, we do need to look at the tertiary relationships we have across the board for all of our services to make sure they're serving the people of Coventry and Warwickshire, or Warwickshire and Hereford and Worcester as best we're able. Any other questions or perspectives on the review given by the managing directors? Move on then to the session on urgent and emergency care and winter planning, preparedness and assurance stocktake. My colleagues, over to you. Who's going first?
Thank you, Chair. That'd be me, Andy Parker, and Gwenny, if you could share the slides for us, that would be most appreciative. Thank you, Gwenny. So this is a prerequisite really to individual board assurance sign-off in September, and this presentation is picking up on some of the common themes across the group in terms of approach, sharing opportunities and learning. So you go to slide 1 please, Gwenny, thank you. So winter planning governance, as many colleagues will know, in June the urgent and emergency care 25-26 plan was circulated, and in that document it referenced various improvements that we've already mentioned here to urgent and emergency care, particularly around ambulance handovers, 78% of emergency access standards, reducing 12-hour waits in RED to less than 10%, 21-day long length of stay, particular focus on children and young people, 4-hour performance in emergency access, and a system approach to discharge planning and development, linked to the Better Care Fund, and a specific mention in that particular document on winter plans and developing winter plans now and making sure they are stress test early. This was followed up in the 18th of June by a winter letter explicitly mentioning the early submission dates for winter plans and stress testing those plans in September, and making sure those plans are robust before we hit the autumn. And that was in across Coventry and Warwickshire and Hereford and Worcester's lessons learned from last winter was around having early sight of plans and stress testing and modelling in efficiency those plans ahead of the winter period, as well as providers supporting developing ICS plans, and that local trust plans are linked to partners across various systems. So across all our all trusts in the groups, we've modelled those plans linked to our UEC recovery, and in the appendix of this presentation, I won't go into now, is the modelling that our information and BI teams have done on attendances and bed capacity, which triangulates with our cost improvement plans, long length of stay and escalation plans, including the workforce impact and implications. Each trust has got its own insurance meetings linked to the UEC governance and improvement and escalation plans. And we've all got real-time live reporting through internal systems such as ED dashboards and ward-based dashboards, and then external escalation reporting through systems such as SRUD, and linking that to our operational pressures escalation levels, or OPAL. Next slide, please. So 3 areas of key focus for our operational and clinical teams, starting with ED. So across all our trusts, we're focusing on navigation at the front door, strengthening the expertise and experience that we've got, ensuring we've got senior decision makers to stream the right patient to the right place at the right time, with robust internal and external pathways for our patients. Maximising our virtual ward and hospital home capacity, ensuring the criteria is correct and appropriate for our patient pathways, both for step down patients and step up patients into those virtual ward beds. Same day emergency care, or SDEC, remains a key theme, particularly around how we're reviewing the capacity, the hours, the criteria and the workforce. And there's various learning from across the group that we're already linked into, particularly the UTC model at George Eliot, the frailty model at Swift, the paediatrics UEC at Wye Valley, and the ambulance pit stop and referring to SDECs, that's at Worcester Acute. But we're all focusing on ambulatory pathways, and Catherine's already mentioned the focus on the non-admitted breaches and ensuring that we have stretch targets for non-admitted breaches, because those non-admitted breaches in ED maintain the reduced impact on congestion. And a number of us have got capital plans in the winter that look at expanding that ambulatory and SDEC capacity as we head into and over the winter. We're all focused on our workforce, ensuring that there's various changes going on, particularly around hours, skill mix, particularly within ED and our SDECs, and also focusing on our sickness in terms of management of policy, but also ensuring that we're promoting wellbeing offers to our staff and our workforce. And also learning from improvements, particularly, as already mentioned there, Worcester being in Tier 1 and the support they're getting from the ESIS team that us, particularly at Wye Valley, need to learn from ahead of the winter. Next slide, please, Gwenny. And then hospital flow. Each trust has modelled its surge and super surge plans ahead of the winter, and how we manage within our core bed base, how we manage our escalation policies, but also how we reduced our reliance on escalation wards, escalation beds, borders, temporary escalation spaces and corridor care. And our plans to unlock barriers to reduce length of stay, because we know that use of escalation beds and borders and temporary escalation spaces impacts on our length of stay, and various schemes around ward-based education and ward-based support in terms of the methodology of thinking home first and pathway zero first, along with various schemes around reducing super stranded, those 21-day length of stay across our acute and community sites through discharge challenge events and MAID events across the period, not just ahead of winter, but during winter as well. And use of ward-based dashboards for timely information and escalation, along with discharge targets per pathway, and per day and per specialty. Various schemes to increase ward 7-day working and on-call cover to support ward flow ahead of the winter, including bolstering medical cover across our wards and take teams and enhanced discharge teams across 7-day working. Protecting our elective capacity has always been a crowning glory for what we've done across the group, and we aim to continue protecting our elective capacity for our patients and for our income plans across the winter period. as well as ED workforce management. That same offering of support and reducing congestion on our wards is key ahead of the winter. And then some of the digital technologies as well. The EPMA solution across a Worcester acute, but ensuring we use digital in other areas, such as in Wye Valley. Here at Wye Valley, we're looking to implement our ward-based whiteboards to support timely flow. And actually, there's a meeting ongoing at the moment between Swift and Wye Valley about how they use their digit system and improve their flow there. And there's a cross-divisional meeting happening while this board is taking place. Next slide, please, Gwenny. And then collaboration, I've already mentioned about virtual ward, not just increasing occupancy, but ensuring that the criteria really does impact on admission avoidance and length of stay, not just hitting the target and missing the point, but adds value to patients and clinical pathways. Then there's the primary care admission avoidance schemes that are happening across our foundation group, particularly focused on frailty, but also expanding our therapy support for discharge pathways. And then visibility of system capacity, particularly around timely escalation and community hospital social care and home first capacity and length of stay through and overstayers as well, and just making sure we've got clearer visibility of where those opportunities are to focus on ahead of the winter. Ongoing work around expanding the urgent community response and single point of access. We've already mentioned call before convey, but across the group, we're focused on how we improve call before convey and how we ensure that paramedics can easily access our community services. And learning also through what Worcester are doing in terms of redirecting their 111 calls to their single point of access and not just ED. We need to mirror that across the group. And also pharmacy first navigation as well as ongoing audits around missed opportunities, so we can learn not just for this winter, but for this winter and beyond in terms of what else we can do to ensure the right patients is streamed and navigated to the right pathway. And then also wider based system impacts. For example, in Wye Valley, the PAWIS assurance around their winter plans, not just around discharge planning, but their same day pathways also. And I'll hand over to Natalie now at George Eliot to take us through vaccination and infection prevention.
Thank you, Andy. As Andy's already mentioned, lots of work ongoing, and part of the work that we all need to do, and I would urge any members of the public that are listening to this, is our vaccination plan for the winter. And going into the winter, we know that last year the vaccination rates across nationally were not very high at all, and particularly for our staff, but also for members of the public. So we need to improve upon that, and all of the foundation group have committed to improving the vaccination rates, greater than the 5% improvement on last year, and the vaccination programmes will run between October and March. We're also maximising on the way that we deliver those programmes and the opportunities for our staff, particularly to receive the vaccine. And you can see from the slide that there are a number of ways that all of us are maximising that effort. But alongside that, we do need to do a bit of myth busting, have our flu champions that can help and support anybody that has any worries about receiving a vaccine, and trying to allay those fears and what that means, but also looking at the human factors of not only for yourself but for our patients and your family. Being vaccinated is one of the true ways that you can help with that, to prevent getting such an illness such as flu or any of the respiratory viruses. But we're also working alongside public health and UKHSA, because there is a national recognition that last year the vaccination campaigns did not hit the mark and there was a very low uptake. So we'll be working alongside our partners to be able to maximise on any publications that come out and to utilise, as I say, that myth busting. And we heard in the board workshop this morning the great work that's happening already with regards to increasing vaccination through Worcester Acute, and we'll be learning from them and what works well so that we can all utilise that. Next slide, please. So we do have to plan, though, for an increase in infections, particularly from a respiratory side over the winter. So good infection prevention control plan is key for all of us. We do have access up to our live data, and we can have a predictive analysis of this data, both from the community and from the acute side. So knowing what's happening within our community is really key for us in the acute providers to ensure that we are proactively managing our bed, our flow, and being able to stabilise the flow in a quick and prompt manner. We've all been reviewing our protocols and policies. We have updated these in readiness for a potential increase in infections this winter. If we do follow our Southern Hemisphere compatriots, then there has been an increase in respiratory viruses and illnesses. So we are being prepared for that. The communication across all of the organisations is key, and what we're all looking at is good infection prevention control. So those reminders to all of our clinical and non-clinical staff about the importance of hand hygiene, about the importance of PPE, and making sure that we have that preventive stock levels in place to ensure that we can face any increase and challenges that brings. There are a couple of areas of concern for all of us, and that is with regards to the amount of side room capacity. So having that predictive analysis and having the ability to test and get those results back quickly is key, so that we can put in place the isolation strategies, but also being mindful about children, and particularly if RSV hits at the same time as adult illness, what impact will that have on the flow, particularly through our emergency care departments? So it's about that predictive analysis, about that proactive monitoring, and having the protocols in place so that we can upscale our isolation processes and to cohort and monitor any outbreaks that we have. I'll hand over.
Thank you. So I think I'm just coming in as a guest speaker on this bit here. In terms of the workforce resilience for winter, it's fair to say that managing the demands on our staff and also managing the demand for additional staff are going to be critical parts of the planning process. And this is done in a number of ways. There's firstly around effective roster management, so really making sure we've got the right people and the skills focused around the activity and the need. But also making sure that through our rostering processes and policies, we make sure that our workforce gets adequate rest to help them perform at their best over this period as well, and help to sustain that activity. The second part is really around managing sickness and health and well-being. And that's not only making sure that we're following our policies and ensuring that people are supported properly if they are off sick or unable to attend work, but it's also doing all the proactive stuff as well. And we've got some great examples across the group of health and wellbeing offers, occupational health support, mental health support, and even things like exercise classes to try and help people stay at their best as we approach this time as well, alongside the vaccination programme that's just been mentioned. And the third area is around careful governance around decision making. So if we need to open additional capacity or additional areas, it's doing so in a planned way, so we can reduce that reliance on last minute temporary agency staff as much as possible, and make sure that again we've got the right people focused around our patients in the way that we need to. I think it's fair to say as we approach the winter period, though, that concern over keeping our colleagues well, that health, well-being and also staff morale are really significant, particularly against the landscape of potential increased industrial action and activity over those winter months. That remains an area of focus and also risk for us. Thank you.
Really great summary. Just
one more slide, Russell.
Okay, apologies, I got all excited.
Essentially, I won't repeat sort of what's been said, but we have put in the pack just a few opportunities for how we're going to work together as a foundation group to strengthen our plan and continue with some of the shared learning. We've talked a lot about all the things that we're going to do. I think working as hard as we can to try and manage the demand within the agreed winter budget is going to be a key action for all of us. That said, I think that's one of the most challenging bits for all 4 organisations, not least given the pressure that we've already seen. In terms of sharing some of that workforce modelling, we've talked about that, and I won't go through the slide, but just to pick out a bit about stress testing. So we are considering how we might, as a foundation group, do some of that stress testing, because we're already going to do it as part of an NHS England rollout. But actually, it feels like we've got a safe environment here where we can perhaps do that in a bit more detail. And then the final slide just talks about some of those key areas for our strategies and what the bed gaps are by organisation.
That's great, thank you. Just before I open it up to questions and perspectives, Chris, can you just give me some assurance about the point I made about the Partnership Trust and the work that's going on there? I know Stephen touched on it, but how are you feeling about, as we enter the winter, and that key risk if we don't free up that flow? What's your perspective?
Thanks, Chair. So I think my perspective is I think we've seen a sort of a step change in terms of how we're able to work with our partners in the Health and Care Trust around some of the reductions we're seeing. Just as an example, 6 weeks ago, there were 76 patients with no criteria to reside on the Worcester site alone. Today, there's 54. So in terms of the ability for partners to support us to get patients to where they need their care to continue, we're definitely seeing an improvement in that. And again, as Stephen touched on in his update, the pathway discharge unit at the Worcester site now routinely has beds that we're having to go and find patients to fill rather than a waiting list of patients to go into it as part of the flow. So we're really seeing those improvements. The other bit is that the system-wide discharge programme, which is about how we identify patients that need a pathway discharge, is due to see sort of the benefits come to realisation, or to start in terms of the implementation at least, at the beginning of September. And in terms of the work we've been doing internally to get ready for that, again, we're seeing the benefits of that already before we've actually done all the actually done the full implementation of that. So actually, I'm really quite confident in terms of how we've started to see those improvements. The one thing I haven't got to hand is what we've seen in terms of the community hospitals length of stay reduction for their internal programme. But I'm really confident in terms of how we're able to work with our executive team in terms of the weekly engagement around the progress we're making.
Super, thank you, Chris. Really important discussion that members of the public may not be able to see in the chat box regarding vaccinations and a drop-off in vaccination rates. I would say to members of the public that despite what you may hear in some dark corners of the web, vaccinations have revolutionised children's and adults' health over the last 50 years. And if you are a parent with a young child, it is an enormously risky step that you take by not getting your child vaccinated in the way health professionals recommend. And the consequences when you see young children who are suffering from avoidable infections like measles because they haven't been vaccinated is tragic. So a very strong encouragement to get your young ones vaccinated. And even if you didn't when they originally came up on their vaccination cycle, to reach out to your GP to get them vaccinated quickly. Questions and perspectives, Glenn?
Yeah, I mean, that's a really good point you've made there, Chairman. I think also based on the communities that we serve, it appears to be a choice thing rather than an access thing, which is incredibly worrying. So great to see the level of sharing between the COOs and those plans that they've all gone through there. It was really reassuring. I think the particular one for sharing for me is looking at some of those electronic bed management solutions, because I think the transparency of immediate availability of beds is a really important part of that flow. Because the killer slide for me actually was the final one, which said we're 188 beds short, just 188 beds short, and that winter plan, that's a big number. But actually, when you look at the average length of stay data across the group, there's a 45% difference between the highest and the lowest. So there's still big opportunity for flow improvement. And so therefore, the bit that I was surprised wasn't included in the flow slide, and you spoke to it, Andy, so I'll just check in with you, was internal professional standards and just checking in on those process timelines that we've agreed with clinicians that will be delivered? Are we refreshing internal professional standards going into this winter?
Yeah, absolutely. The way we're working together standards, not just our board based, but in terms of expectations, in terms of specialty responsiveness to our EDs and our SDECs. So absolutely, that is a key piece of work ahead of the winter as well. And that work has already started.
Great. Okay. Thank you.
Can I take it up outside with Stephen and Adam, but you may want to get yourself briefed. One of the things I think would be really helpful on this issue of flow is a consistent measure of either the flow coefficient or the flow velocity we have across the 3 trusts and the pathways within the trusts. I'm not sure if my COOs get that anyway, but there are measures like flow coefficient to see the efficiency of flow through a system. I just think it would be a really helpful measure to see that across each of the trusts and within the trusts where the blockages are. I know you'll know that, but having a consistent measure, which we all see. So if we see a number of 0.9, that we know that's a good number compared to a number of 0.3, but making this bit up. Swift's at 0.3, Worcestershire's at 0.5, George Eliot's at 0.6 and Wyre's at 0.4. At least then we understand where the improvements are available in terms of flow. So can I ask you to take away, do a little bit of homework, speak to the data analytics team. But I think as we approach winter, having a consistent measure of flow efficiency would be very helpful to all of us. Simon Murphy?
Thanks, Russell. It's a similar-ish question to the one that Glenn asked about internal professional standards. Where are we with our consultants on things as basic as ward rounds in terms of discharge? Do we have a consistent process where the people who need to be seen immediately are seen by a consultant and then we work on the discharges, or do we still have consultants going around from bed 1 to bed 20? I mean, where are we on that across the group? Okay,
great question. Have we got an immediate answer? Fiona's hand bravely went up. But I think it would be good to minute it as well, Simon, so we get answers across the group. But Fiona, what's your view on this?
I can say that we are refreshing our board round SOP, which clearly gives out, it spells out responsibility to go to the sick patients first, the dischargeable second, and then everybody else, as well as other things. So I can share that if other organisations don't have it, but that's what we're refreshing before winter.
Yeah, no, that's great. Bhaskar, did you want to add anything to Fiona's point or not?
Yeah, I want to say that the internal professional standards will reinforce it, and it will also reinforce the weekend ward round expectations and the criteria-led discharge embracement across all areas.
Okay, I do still want the point minuted so I get answers from across the foundation group, but Chris?
Thanks, Chair. So from a Worcester acute point of view, Simon, on that particular point, part of the ESIS support we're getting now, we've said we're doing some work with them specifically on our board and ward round processes in line with best practice. So once we've sort of implemented that as a train the trainer programme internally, we're very happy to share that with group members why it's consistent.
And Catherine makes an absolutely key point in the chat box about the risk appetite thresholds of different consultants. And as I understand it, their legal responsibility is to the patient in front of them, rather than thinking about risk through the system. And that is definitely one of the challenges, which goes back to the internal professional standards debate. Stephen Coleman?
Yeah, it's a slightly separate point. It was more around how I was really struck by the wellbeing one. And again, I think, Glenn, your bit of, if you look at the gap for beds, it's big when you add it all together, but actually 30 beds for Worcester might not seem the biggest it's ever been. I'm a bit nervous, and I think we might just have to think this through, that we kind of take this approach, particularly when we talk about the wellbeing. It's a bit like we sleepwalk into this every winter. And actually, if we change the narrative a bit of, it's a profile of demand. And going to Natalie's point, I think we can be much better. And partly what I want to try and do with Andy and Chris is, if you look at the Australia, it's fairly stark that we do follow a pattern every 6 months, and the predictability of what we're going to see, I think is more there than we may think it is. But I'm just a bit nervous. We run into a narrative with our staff. It's a bit like winter happens to us. It's terrible. And therefore, we kind of create the psychological space for them to feel really battered by the whole thing, rather than us really focusing, I think, on that flow thing and what we can actually control ourselves. So I think something for us to think about, and certainly for the two trusts.
No, absolutely good point, Stephen. Thank you. And Robert, then we'll move on.
I appreciate the discussion has been focusing on flow and beds quite rightly, but I was interested in the slide that referred to extension of alternative healthcare provision, so primary care 111, making sure that people are coming in under their own steam, are directed to the right place. How do we know whether those alternatives are working? What sort of monitoring is in place to see whether those plans are achieving what they intended?
A great question again, Robert. Does anyone want to give a first perspective? But I will get that again popped into the minutes so we get answers from each of the bits of the foundation group. Harkamel, thank you, and then we'll move on.
Yeah, I think it's a really important question, and as part of the summary side, we did include that we are engaging with external system partners to make sure that their plans are robust and well resourced. I think it's going to be something to watch though with the change in the ICBs and making sure that actually we don't lose focus on this. And as part of the stress testing that we're going to do with NHS England, certainly from the SWIFT perspective, there is that dimension of we know that we need more robust mental health plans, and actually we have seen really significant waits. The way that the ambulance service works across our patch and how we manage some of those flow challenges is vital, as well as it then GP hours, extended hours that have worked really well in the past. So this is some of these conversations have been had at place in the various forums, but I think that's a really important point to minute, and it's an action that we can all take away as clues in terms of making sure that as these conversations happen, because we have very well established winter forums, that we're feeding some of that challenge back in, because in the acutes we will see then the impact of not having adequate services out in the community to prevent that admission in the first place, or in the first place.
Yeah, no, great. Thank you, Harkamel. Really interesting couple of points in the chat box. Jeremy Spearman, who's one of our Council of Governors staff members and an extremely experienced clinician, makes a point about the challenge of discontinuity of care when patients leave us, and the important risk that represents, particularly for those with long-term conditions. Point well made, Jeremy, thank you. But Fiona also makes the incredibly important point, because we've been affected by this ourselves, that we do need regulators who are maybe watching this meeting to appreciate that there is a balance between risk of the individual against risk of the system, which our clinicians all the time are having to make, but regulators don't always consider. Really good broad discussion, team. Thank you for your contributions. Thank you for your leadership, Akuz and colleagues. We'll move on then to the Equality Update Report and my Chief People Officers. I'm not sure who's going first on this, because Swift is first in the pack, but I'm not sure if who's leading on this item. Over to you, Tim.
I'm going to just deliver a quick summary, Chair. I'll take the slides as read, deliver a summary of some of the key points that as a group we're all progressing in this space, and then just invite other CPO colleagues to come in if there's any particular points that they want to highlight in addition to what I've covered. So just for context and for members of the public as well, the slides that are within the pack sit in addition to individual equality reports that each trust will have uploaded into their website space as well, and that will be available for further detail as well. But this highlights really just some of the areas where we're seeing particular progress over the past year, and areas that we're also collectively very proud of as well. The key bits I wanted to highlight are things that we're all collectively progressing. And the first one is really the huge encouragement and pride that we have in the range of staff networks that we have across the foundation group. And we see some variation at each trust in terms of the names of some of those networks, and particularly the groups of staff that will attend or be involved in those networks. but collectively they are a safe and inclusive space for staff members to come forward and proactively discuss and take action around inclusivity and particular protected characteristics, although they're not an exclusive space either. We really encourage allyship in these spaces. And each trust has a really growing source of engagement with our workforce and community in those network spaces. And that engagement is really critical. It's really enhanced and augmented by the staff survey data and engagement that we have on an annual basis as well. And that feeds our race and disability reporting, which are statutory requirements, but also it gives an opportunity to take localised action and really focus in on action plans for areas where we might be struggling under some of those indicators that we look at in the staff survey, and that gives us that year-on-year progress. And each trust has reported within the pack some of the work that they're doing on that staff survey data and some of that action planning as well, which is really positive. As you might expect, we are all collectively focused on inclusive recruitment, but we see different examples across the trust in terms of how we are widening access and how we're making sure that our recruitment processes are inclusive. But not least to make sure that applicants can have a fair process, but also to encourage that access from our communities to employment opportunities as well, recognising what a huge employer we are across the regions that we serve as well. Training and development plays a really significant part in tackling inequality and poor behaviour, but also in promoting a message of anti-hate across our trusts as well. And we've got some good examples within the pack there of different examples of the training initiatives that we are bringing about, from active bystander training to more specific training around things like neurodiversity in the workplace. And it's also, I think, fair to say that across each trust, we're all working quite proactively in the space of neurodiversity now, with a range of different toolkits and resources and training available for people, all being implemented. Recognising that I think now the number is approximately 1 in 7 people in the UK have neurodiversity of some description, and they are the colleagues that know about their neurodiversity. But I think it's fair to say that we're growing awareness each week on this, and actually doing what we can to really embrace the support for our colleagues with neurodiversity and make sure that we can help everybody be the best they can be in the workplace as well. I will pause there and just invite my CPO colleagues if there's anything they wanted to add in addition to what we've covered in the summary.
Thanks, Ali. Sorry, Elva, I was just jumping in there without putting my hands up.
I tell you, Jeffrey, I've always regarded you as a sartorially elegant gentleman, and there you are jumping in front of Elva. I'll come to you in a second, Jeffrey. Elva.
Thank you. Can you all hear me, first of all?
Yes, I can.
Fabulous. Yes, thank you, Ali. That was really helpful. And I think the only thing I really wanted to add was to really highlight around the staff survey results. As nationally, the results across all the themes were broadly flat, although particularly the engagement score dropped for acute trust. So for all 4 of our trusts within the group, it improved. So that was a significant achievement. I don't know whether back when the results came out, there was a very helpful graph that went around which showed where each of our trusts were, and we were all within the strong and improving bracket, which is a really, really great achievement. And that engagement score is really important as part of the wider EDI work that we do to ensure that our staff feel that we are engaging and listening to them.
Okay, thank you, Elva. And Jeffrey.
Thanks, Russell. The only other point I'll add is the fact that promoting EDI and tackling health and workforce inequalities are now part of the performance appraisal framework for all board directors. So it's one of the key requirements now as part of the performance appraisal. So we're going to be working on that. And also across the foundation group, we are determined to push through this inclusive and compassionate culture. And we are encouraging all of our senior managers to sign up to the NHS Inclusive Leadership Pledge so they can lead with kindness and compassion in terms of their daily operations within the foundation group. And the staff survey, as Elva has covered, really demonstrates the significant improvements we've made in terms of trying to create that good culture, the good working environment, and we're taking our obligations on EDI very seriously. And finally, all the things that we're doing, we are doing those to try and meet the NHS People promise for our staff about that compassion and kindness. And also, ultimately, EDI is about the employee experience. So everything we're doing is about trying to create the right culture, the right working environment, and the right experience for every single person across the foundation group. So I just wanted to outline those points as well.
Okay, super. Thank you, Jeffrey. Some important points popped into the chat box about some of the really unfortunate and unacceptable conversations that are happening in society generally. And I think the point you make, Jeffrey, about our culture being one centered on kindness and compassion is absolutely essential. It's an absolute requirement for all leaders, and we're all leaders, whatever our role is. We're all ambassadors, whatever our role is within the 4 trusts, need to behave in a kind and compassionate way. Civility saves lives is the reality of the work we do in healthcare, and we should be absolutely at the forefront of behaving in a way which is commendable, whatever is going on in society around us. And I'd like to particularly to call out 2 Neds before I go to questions and perspectives. Simon Murphy and Ollie at Swift. Simon Murphy at Worcestershire. The work you do with our networks is fantastic, and our volunteers, in terms of supporting them, knowing that we value the work that they do. So I'd just like to thank you 2 in particular. I know you're not the only 2, but I'd like to have a shout out just to the 2 of you in particular. Any other questions and perspectives? Catherine?
Yeah, thanks, Russell. Really comprehensive list of all of the things that are going on. I think for me, one of the things that would strengthen this report even more is if we had the data, and I'm just not sure if it's where we are in the reporting cycle, but it'd be really great to see the impact of all of this work that's going on, and particularly if there are amongst all of these different things being done in different ways, probably there are some areas that are being really effective and some that might not be as effective. So it'd be great to learn from where that's really making an impact on the things we can measure, like likelihood of being shortlisted, or our colleagues' experience of whether there's progression and those sorts of things. So it'd be really great to be able to compare all of this narrative to the data, if that's possible.
Good challenge, Catherine. Any other questions or perspectives? Okay, team, thank you. Keep up the great work. But it is about us, I think, particularly as board colleagues, to lead from the front and to demonstrate that kindness and compassion to everyone. So we will move on then to the NHS oversight framework. Members of the public will be aware that we have, throughout this year, effectively lost our Group Chief Executive, Glenn, to his national service at the centre of the NHS, trying to ensure that the NHS thrives, given the challenges it's had over the last few years. So one of the key aspects Glenn's been working on has been the new oversight framework. So Glenn, over to you.
Thank you, Chairman. And it's always lovely to come back to group boards from all of that other stuff. So we've already referenced the oversight framework a few times in the course of the meeting, particularly when we're talking about some of the performance issues. So I'm just going to talk through that a little bit. I've included the paper that went to NHS England board because it's easy just to use that paper, but also because it gives a little bit of a flavour of the feedback that came back from the consultation exercise that we launched earlier in the year on this. And this was a consultation that moved us from a bigger range of indicators feeding the oversight framework into something that is a bit shorter now and more focused. And for me, it is focused on those priorities that are linked to the planning guidance that we saw at the start of the year. One of the things that we need to be aware of with this new oversight framework is that it is rules based, so it's not judgmental in the way that previous segmentation has worked. So whereas previously you could be performing well but knocking the door to ask if you could go up a segment, now if your performance is better you will go up a segment. We haven't included the data here for the trusts in the group because we're at the stage now where we have provisional Q1 results, but they will not be finalised until we get to the middle of this month. And so towards the end of this month, we will see the final Q1 data. And the reason for that is some of the data feeds, like cancer, are reliant on the superstats, which come out in the middle of August for Q1. And then we'll get into that rhythm for the rest of the year. It is a ranking system, so one of the things that we also have to be conscious of here is if you stay the same but others around you do better, then you will fall down the rankings, and that's something that people are starting to get used to. The other bit that is important here is there's two things that this will feed. Firstly, a set of freedoms and incentives, and I'll talk about those in a moment. But then secondly, at the lower end of the spectrum, an intervention regime. So at the moment, we segment into 4 quarters, but that fourth quarter goes through an organisational capability assessment in order to determine whether those organisations should be segment 5, which is called the Provider Improvement Programme, which is has been called various things over the year, but it is a national intervention to try and ensure that those organisations can improve their performance. There's 3 elements to this. There's the operational performance elements like cancer, RTT, A&E. There's finance and productivity, and then there's quality, and also within that quality indicator there are things like the staff survey, which we've already mentioned. So we try to capture a whole balanced scorecard of issues. I think one thing that is really apparent in this version of the oversight framework is that acute providers have a lot more indicators than some others. And particularly if you have an A&E, which all of our trusts do, then that's particularly challenging from a performance perspective. So some of the specialist trusts, for example, even though they're on the acute list, they're generally specialist trusts at the top of the ranking mainly because they don't have an A&E to deal with, would be my perspective on that. The freedoms that we're going to link this to will be, there'll be a number of them. One of them will be the new Foundation Trust pipeline, which we are just working on the details of. And organisations that can go into that pipeline also have the opportunity to become integrated healthcare organisations for a very small number of them. So there's some really important prizes here. Capital freedoms, another one we're looking at. And therefore we're trying to get to a position where if you do well, there are incentives to do well. And if you need support, it's identified early and you get support. We've added a financial override to this process, which means that any trust in deficit or in receipt of deficit support funding cannot score higher than segment 3. And we'll keep that override going. We are going through a process of resetting the block contracts, particularly around urgent care, and that will help in most cases to ensure that those organisations doing the activity get paid for the activity, which will help that reset. You've already, Chairman, talked about one of the things that I think we just need to reflect on as this lands, which is some of the indicators look at the plans of the individual organisations and assess from a board governance perspective whether the organisations are delivering the plans that they signed off. And that's one thing that therefore means that we need to pay more attention to the profile of our plans over the quarters of the year, because that's something that we could be caught out on. And then also, I think in the future, we need more indicators that support some of the aspirations of the 10-year plan, like some of those out-of-hospital indicators, prevention, tackling inequalities, but it's fair to say the data sets on some of those things are less mature than some of those indicators I touched on earlier. So I'm happy to take any questions on it. In the cover paper, there's a link into the NHS England website where if anyone wants to get into the detail of it, it's all there. And at our next board meetings, each board will look at their individual scores, and we'll also look at the rankings of the trusts against the national list. Thank you, Chair.
Thank you, Glenn. And like I said, thank you for the work you're doing on behalf of the whole of the NHS. Questions and perspectives to Glenn? We've obviously, for members of the public, spent a lot of time talking about this in different form, but Catherine.
Yeah, Glenn, I was wondering if you knew when the likely reset was going to happen. Is that likely to be in this financial year or next? What's the likelihood of the payment by result changes coming in?
So a data capture process is already starting. We are going to be working with the centre to look at the activity reset for each of the organisations. I was looking at some data actually earlier today that shows just the increase in UEC activity in the trust. So what we will do there is reset based on the current tariff and then move into a marginal rate of tariff above that moving forward. The timeline for this is still being debated, but I expect us to certainly know the adjustments during this year. But also we've got to make sure from a national perspective that we keep our eye on the ball in terms of delivering this year's plan. So I don't think it will change this year's plans, but it will change next year's numbers.
Thank you, Glenn. Thank you, Catherine. Francis?
Thanks, Glenn. Very helpful and very clear. Having been involved in performance management of NHS organisations for a very long time, I definitely welcome some streamlining. I think over the last few decades we've continued to add things and never taken things away. So, and I like the fairness, in inverted commas, of something that gets rid of any subjectivity. So support that. But of course, we know that where the clock isn't necessarily where the impact can most valuably be applied to make the change. So, yeah, the fact that there is a clock in our emergency departments makes it easy to count that. But we know that a focus on early intervention, prevention, and all the things you referenced about patients that can likely access urgent care elsewhere can be misleading. So as board, we need to continue to focus on some of the causes and the upstream interventions that we need to make in order to affect those things. But I certainly welcome fewer targets and more clarity on what good looks like.
Yeah, I think that's a really good point, actually. One of the challenges back on this is that going down to individual organisational accountability, does that affect compromise system working? I think just clarity on who's accountable for what, but actually the solutions, as you imply, require us to work with partner organisations in a positive way that improves care for patients. So I think we need to use this, but then continue to collaborate with those other bits of the pathway that we can jointly improve, hopefully.
And Stephen.
Yeah, just a couple of bits. And I think building on that, I'm with Francis. I think one of the things that comes out of this, that we get a clearer pitch on who's asking us what and what the regime that we're working in at the minute. We probably could have 6 different people all looking at it, taking a subjective view, tiering, undertakings. There's a whole raft of things that we get asked about, and I think this makes it a lot better. I guess one of the things, Glenn, maybe a point, but as a reflection, is 2 things really. One is the speed that you'll go in and out of tiering obviously needs to gear up, because if we look at Y Valley as an example, there's 3 months there, but then if you look at it now, we're about to go in, and then realistically you'd be saying how quick can you come back out again. That's going to be slightly different than it's been experienced in the past, isn't it? Tiering's been seen as more of a bit more long term and you're in it. So, and I think my other bit is just probably for board and members of the public watching. I think the approach to planning is the right one about are you on plan, are you off? But I think this year is a bit of a bumpy transition year because I don't think we've had that before. So I think people may have been encouraged around plans to, the classic, that's the wrong number, sign up to this number. I think this year is going to be a year of transition for us, so it might be a bit bumpy as we get through it, but we get into this new regime and new style. I think we'll be a lot clearer and a lot better in the long run.
Yep.
Yeah.
No,
Could I just respond to that, Russell, if I may? So really good points there about. So there's still some work to be done to ensure that tiering is suitably connected into the outcomes framework, and for the public's benefit, we tier national interventions on things like cancer, elective, and urgent emergency care. So we need to ensure that is more rules based. And one of the objectives for that, for me, is when you go into tiering or when you go into the provider improvement program, you're really clear to the organisation what the measures are to get back out of it. So that the entry criteria and the exit criteria are absolutely clear to everyone. So as you imply, hopefully that means that we can be really clear in our first meeting around Wye Valley, for example, exactly what people expect and for how long in order to get back into kind of our normal rhythm. Thank you.
And on the subject of Wye Valley, Jane?
Yeah, just the last issue then, I guess, is the financial override. I mean, it does seem to me a bit of a pity that for everything else we've said, how far are you from plan? But on finance, we've said, if you're on plan, doesn't matter if you've got a historical deficit. Recognise the reset of urgent care and all of that will help. But it does seem to me, for those of us who are going to have a plan over a number of years to get back to break even, it's not going to be something that's done over a single year. It would be great if we are performance managed on meeting our plan rather than a number that we probably won't reach for 2 or 3 years' time.
Yeah, so within the oversight framework itself, organisations being on plan is a positive. It gets you more points. But the override actually means that if you're in deficit or in deficit support, receipt of deficit support, you can't go better than the 3. I think that's necessary. Obviously, it affects 3 of the organisations in the group. If Jim Mackey was answering your question, he'd say you can't really be seen to be performing well if you're spending other people's money, and that's the line he takes. So I think we therefore need to make sure we've got a fair methodology of allocating the money, and we still haven't got that yet, as I touched on earlier. But when we have, I think for all of our organisations, it will be, let's plot a 3 to 5 year trajectory that gets us into break even, and then Wye Valley today would be in segment 2 if it wasn't for the override.
So I understand the rules. I just would like them to be otherwise, but understand.
I think the counterbalance is, we know within our geographies, some trusts have had enormous level of deficit support, which has disguised the true scale of the productivity and financial challenge they have. And so I think the sooner we get out of this funny money allocation system that we've had into a cleaner understanding of which trusts do have and what the reasons are for their underlying deficits, the better. So Glenn, carry on doing what you're doing. Keep us briefed. Thank you very much for your hard work. We move on then to the Foundation Group Strategy Committee report from the 17th of June, which I will take as read. We talked about a variety of different things. I guess my particular frustration at the moment, just so everyone is aware, so there's total transparency, is procurement and us really capturing all of the potential from procurement across the Foundation Group is still an area of enormous frustration for me. And I think over the next couple of months, we need to find a more capturable solution to the procurement opportunities we have, but we'll come back to that. Any questions on that report? Okay, thank you very much. So I think we're on to any other business. Any other business, team? Please raise a digital hand. Can't see any hands being raised. So questions from members of the public. Have we had any questions from members of the public, Gwenny or Sarah?
We haven't had any submitted.
Okay, any questions from members of the public or governors who are on the call? Jeremy.
Thank you, Chairman. Excuse my naivety in asking this question, but I just wanted to ask about clinical research, in that we've heard a lot about organisations continuing to do what they've always been doing and trying to do it better, but I've not heard much about clinical research and innovation. Is there a separate forum in which the foundation group talk about an aligned strategy for adopting clinical research and innovative practice?
Okay, great question, Jeremy. Actually, Adam and I attended a meeting with Warwick Medical School just last week on that very subject. Catherine, do you want to go first and I'll pass to Adam?
Yeah, well, I was going to say that we are trying to work better across the group in terms of research. So we have a group lead for research. And once the summer holidays are over, the plan was to try and get all of the different research leads and the CMOs together from the different organisations in order to identify the opportunity to do more together, because based on the size of the group, there's a big opportunity for us to do more, not only in terms of doing more general research, but also to attract income into both all four organisations through research. So I think it's an excellent question, and certainly one that we're already working on, trying to collaborate better together.
Yeah, and you know, I would love every single part of the foundation group to be a university trust. And when you look at the great work, for example, at George Eliot on education generally, and the relationship it's got with Coventry University, you know, there's so much more we can do. Adam, is there anything you wanted to add?
No, I think Catherine's got the key point. Just following up on your point, Russell, about the conversation we had with Warwick Business School. I think there are some really good opportunities to work further with them, both on research and leadership development across the group. And Stephen and I had a conversation yesterday about what that might look like. So we'll update boards when we've got more information.
Okay, super. Any other questions from members of the public? I can't see digital hands raised, so I will therefore draw the meeting to a close. Again, immense thanks to Jane and Anil for their years. 45 years. Jane obviously joined the NHS at the age of 8. Can I suggest to colleagues that we pull forward the confidential board? So we have a break until 3:20, and then we get going with the confidential board. So we've got just over 5 minutes for a comfort break. See you then. Thank you, everyone. Take care.